I'm going to talk about the indications of MRI for neurologically intact patient with thoracolumbar fractures. I have received a grant from the AO Spine for multi-center validation of CT criteria for ligaments injury. I think when it comes to the indications of MRI for thoracolumbar fractures, we have to distinguish between two major group of patients. Patient with neurological deficit, we do MRI for cord assessment, and this is more established. On the other side, patient with neurologically intact, the major reason we do MRI is for assessment of the ligamentous injury known as posterior ligamentous complex, and given its role in the current classification system. So according to the AO Spine classification, posterior ligamentous complex differentiate between type A and type B fractures, and type B are more prone for surgery. The problem is the indications of MRI for a neurological intact patient is not well established. The Congress of Neurosurgery has published a systematic analysis in 2019, which showed that only 2 papers with a total of around 130 patients showed that MRI can change the fracture classification or decision making, which gives a level 3 evidence, very low evidence, which might explain the variations in the indications of management in clinical practice. We can see 2 schools. The one which is we do more MRI, which leads to delay the treatment, increase the cost of treatment, and complicates the diagnostic pathway. And the other one is people who choose based on their understanding of the pathomechanics of injury. And we know that we have high incidence of missed BLC injury. I think Dr. Shnaka has paper citing about 29% missed ligamentous injury in CT. So I think the right questions, if we are going to make a guidelines for the indications for MRI, I think the right questions for me is how often MRI is going to change the fracture classifications, how often is going to change the decision making, and finally, can we predict which patients, which fracture, which injury characteristics that the MRI would impact the treatment decision. So the first question is how often MRI change the fracture classification for thoracolumbar fracture. I think various papers have cited from 30 to 40 cases, but the problem is, this analysis is it's an exercise of CT accuracy versus MRI accuracy, and the problem is given the lack of standardized CT criteria for ligamentous injury and the poor reliability reported for both CT and MRI, it's hard to reproduce this number or give any meaningful for this. Most of our work is focused on the standardization of CT and MRI. So we published the imaging algorithm in global spine surgery for ligamentous injury. We also published about our proposed CT criteria for ligamentous injury. So in this criteria, we find that there is 4 CT finding which independently associated with posterior ligamentous complex injury, horizontal laminar fracture, spinous process fracture, interspinous widening greater than 4 millimeters compared to the average of the above and below level, and facet malalignment. In this criteria, we excluded vertical laminar fracture and facet joint widening if it is not associated with subluxation, because we didn't find any independent association. So the number of positive findings out of these 4 findings can predict the probability of ligamentous injury. If you have negative CT scan for all findings, the chance of ligamentous injury is only 9%. Actually, it is 5% in our new data, which means you can with sufficient degree of accuracy, you can rule out ligamentous injury and assume that this is type A fractures. If you have 2 or more findings, the chance of ligamentous injury is about 91%, which is again sufficiently high to rule in ligamentous injury or type B. The problem is patients with a single CT finding, they have intermediate probability of ligamentous injury of around 33%, which is insufficient to rule in or rule out ligamentous injury. So usually we can assume that this is indeterminate or suspected ligamentous injury, which is known in the AO classification as M1 modifier. How this translates into the indications of MRI, you can, obviously the indeterminate or the single CT find group will need MRI compared to the other groups. So we talk about the previous analysis, and we have a recent systematic analysis about the impact of MRI on fracture classification, which is still under publications. In this systematic analysis, we include 4 papers. One of them is ours, the previous 2 papers, another paper from Turkey. And what we found is like the chance of MRI changing the fracture classification is 17% due to change in the posterior ligamentous complex injury. And very interestingly, the majority of these cases is due to overlooked ligamentous injury. So the MRI is going to upgrade the classification from type A to type B. The downgrade from type B to type A is, interestingly, is very low consistently in all 4 papers. So we have to worry more about overlooking BLC injury in CT rather than overdiagnosing. So this is, I think, the best answer for this part. The second question is how often MRI change the decision making, and why we are talking about the decision making versus fracture classification. I think the reason is there is 2 major players in the decision making of thoracolumbar fractures: bony instability and ligamentous instability. And not every change in the ligamentous injury status will translate into a change in the decision making. For example, like this case, a patient with unstable burst fracture, if you change the fracture classification or ligamentous injury using MRI, is not going to make a change in the decision. And so you can argue that the change in the decision making is more valid criteria to guide the indications of MRI. But the problem is this is prone to our disagreement about what is unstable fractures, which is depends on regional variations, which was well established. So if you are treating burst fracture conservatively, you have to worry more about ligamentous injury than if you treat them surgically. Again, this is our meta-analysis, which is still under publications. The chance of changing the decision, treatment to decision, is around 22%. This is from the 4 studies available, and it is more commonly due to change from conservative to surgery than the opposite, which is aligned with the upgrading from type A to B. I think the next question is, can we predict the cases which the MRI is going to change the fracture classification? And I think this is the most important question, because most of the disagreement about the MRI indication is related to our inability to provide clear guidelines, clear predictors for the change. We appreciate that MRI, the cost, the time, the effort, treatment delay is very important. So the idea is to reach a cost-effective indications. The black circle is the impact of MRI, and the yellow circle is how many patients we should do MRI to avoid missed ligamentous injury, and how close are the 2 circles will dictate the cost efficacy of indications. The problem is we don't have a lot of studies which analyze the predictors of a change in the fracture classification or decision making, which is not surprising given that we don't have standardized criteria. But in this paper in the Global Spine Journal, we have analyzed the predictors using our CT criteria. So the M1 modifier using our criteria, which is single CT finding, was associated with 24% chance of MRI upgrading the classification versus 6% if you don't have single finding. And the interesting thing, if you combine the M1 modifier with A3, A4 fractures, you will have interesting patterns. For example, A3, M0, according to our data, they don't have any chance of ligamentous injury in MRI. But A3, M1, they have 20%. So this data can help the individual decision making. So it seems like the combination of M1 modifier and the fracture classification may be helpful. So for the A4 fractures, A4, M0, they have 7% chance of upgrading versus 32% with the M1 modifier. So it's still significant. Another way to look at this is the AO injury severity score, which is, I think, is very important and one of the most important things which happened in the last few years. It guides the decision making according to the scores, very similar to the TLIX, but it assigns different score for A3, A4. And if you look at this also, it can help to guide the indications. So you find that in the conservative treatment group, the chance of MRI changing the decision-making from conservative to surgery is 7%, not very high. In the surgical group, it is only 1% from surgery to conservative group, from the dark gray to the white. But it can change in 21% from surgery to conservative. But if you look at the gray zone, the chance of MRI changing the treatment decision from gray to conservative is 22%, and from gray to surgery is 11%, so the total is 33%. So you can consider the gray zone in this perspective as an indication for MRI, so like a diagnostic gray zone instead of the therapeutic gray zone. Another interesting perspective is the spine region. So we have never analyzed the impact of the spine regions, which have different anatomy biomechanics, like low lumbar fractures, thoracolumbar junctions, and the thoracic on the ligamentous injury classification. But we published this in European Spine Journal, which found that low lumbar fracture MRI has very negligible impact on the fracture classification. And I think most people agree on that. This is a distinct group. The lower doses, the size of the fascious side of the vertebral body. So it's very unlikely that if you have a ligamentous injury in low lumbar fracture, that will be very severe and most probably associated with neurological deficit or polytrauma. So what is next? I think the next step is we know this variable. It's not based on our observations in around 250 cases. I think the next is how can we integrate all this variable in a machine learning algorithm to reach guidelines for when to do MRI for thoracolumbar fractures. We already did the preliminary, but now we have like 750 patients from our multi-center study. It's underway. I think the take-home message is regarding based on our data, I think the best indicator for the need of MRI is indeterminate ligamentous injury as determined by a single CT finding. This criteria is now under validation in a multi-center fashion, and probably machine learning in near future will provide better evidence-based guidelines for the need for MRI. Thank you very much.
Thank you, Mohammed. Excellent way of explaining the pathway, how to find the solution. And just a question, who of you always performs an MRI in thoracolumbar trauma? Always, like in more or less every case? One, oh, there already. And who of you would say just in certain cases where there's suspicion of PLC? Okay. So the ones who just heard, who say, I perform an MRI always, does this talk change your mind now, or did it change your mind a little bit? Because what you said is that it makes definitely sense in the specific cases where there's a suspicious, where we have a modifier, etc. Then it may change, typically otherwise not. Any comments from the ones who perform always an MRI? Or are you going home and reconsidering what you're doing?